This episode is sponsored by our global research partners. Want to contribute to the advancement of medicine? Make some easy money while sharing your thoughts with market research surveys. Learn more and sign up using the special TFOC link on our website and in the description box below.
Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the HEMONC podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And today's episode, we talk about AML maintenance therapies. And we are just continuing on our AML journey. We've covered a lot of really important ground, and we're slowly starting to make that bend coming towards the end of this series, which is exciting, but we've really, guys, we have covered so much ground. It's like kind of exciting.
Yeah, we've talked about a lot of stuff. I mean, honestly, I'm about due for another series, but we got to power through it. We got to finish this out. So today will be a good discussion on these low-intensity therapies, these maintenance therapies after something like intensive chemotherapy or a transplant.
Yeah, it's been a great series. A lot of that history stuff was new to me in terms of like 7 and 3 and all that. So I'm excited to see what we're going to talk about today.
All right, guys. Well, then without further ado, let's roll that show. So I'm going to apologize to our listeners and to Vivek and Dan in advance. I am puppy sitting for the very first time in my life, and I thought I would have the help of my wife, who is actually not home this evening because she had to do something for work. And so my brother's dog is actually sitting right next to me as we speak. So I apologize if I seem frazzled or if you hear a bark in the background.
It's the best thing to do to have your little companion with you. Lola is always around the recording area that I'm in, and she has her little clitter-clatter of her feet. But luckily, whatever our recording is, it's not picked up, so I'll take it.
That's good. I'm still working on Logan to get a pet, but if I do, I'll make sure that pet is in attendance and recording as well.
There are multiple times, actually, where our cat is literally like sleeping in a little bed in the side of the closet, and she's just like curled up there, just kind of hanging out. And so she's part of the podcast, really. I don't think anyone knows that, but she tells me all the time that she has a podcast, and it's clearly this one. She owns it.
I didn't know you were a cat whisperer, Vivek, of all things,
Yeah, I communicate. Lily and I communicate really well. She's very communicative.
Truly, yeah, so many talents, such a talented man. Speaking of which, Vivek, you're also quite talented at hematology topics. And so I heard that you have another case for us to kick off our episode today. So do you want to get the ball rolling?
Yeah, so we have a 72-year-old female with intermediate risk AML who underwent intensive induction chemotherapy with 7+3. On initial workup, she had FISH, which did not show evidence of a high-risk deletion or rearrangement. Targeted molecular profile was negative for IDH1, IDH2, FLT3-ITD, FLT3-TKD, and the biallelic CEBPA BZIP in frame mutation. She was deemed fit for intensive chemotherapy, so she was started on 7+3 as a standard of care that we've talked about in the last several episodes. 2 weeks later, her karyotype resulted, which showed translocation 911, and NGS did not have any evidence of a high-risk mutation. This put her at that intermediate risk by the ELN 2022, given her translocation 911. Remember, always look that stuff up. Her induction course was complicated by neutropenic fever and cholecystitis requiring percutaneous drain. She had a significant decline in her performance status due to these complications. Fortunately, though, after count recovery, her marrow showed a CR. She was evaluated by the transplant team, and at that time was unfortunately not deemed a good candidate for allogeneic transplant for a variety of social reasons and partially the decline in her performance status. We're now planning on HiDAC consolidation at 1 gram per meter squared on days 1, 2, and 3 with GCSF support. She comes to the clinic to start consolidation and asked about a new study she saw on the internet about a pill maintenance chemotherapy that improves survival in AML. So let's get into discussion on oral maintenance options in AML, either post-intensive induction or post-allogeneic transplant. First, though, can one of you recap our prior episode on the cytarabine consolidation? Lots of material. We just want to reiterate it one more time.
Yeah, definitely check out that episode and go to our website, which has all the details with links to all the pivotal studies in our show notes. If you haven't done so already, the show notes are invaluable. Our team does a fantastic job with those. For patients treated with intensive induction chemotherapy, there were early studies in the late 70s and 80s that showed patients who got no consolidation, cytarabine, had 100% relapse risk and poor overall survival as a result. 100%. It's not often that we see that in medical literature. After numerous randomized trials in the 90s and 2000s, we found that high-dose cytarabine at 3 grams per meter squared, given on day 1, 3, and 5, every 28 days for 3 cycles was the way to go for consolidation. And the patients who had a donor could proceed directly to allogeneic transplant, regardless of how many consolidation cycles they received. The problem was that patients older than 60 had a very difficult time tolerating those higher doses of cytarabine. And there was data to use a lower dose at 1 to 1.5 grams per meter squared on consecutive days 1, 2, and 3, with GCSF support with less toxicity. There was some weak evidence in a network meta-analysis that those lower doses may lead to an inferior relapse-free survival. And there was only one prospective study in the UK that did not show a significant difference, but a trend towards worse relapse-free survival with lower doses of cytarabine. But again, we're talking about trying to get people some therapy. We know that without anything, there's a 100% risk of relapse. And there are really high complication rates at those higher doses. So we still feel like those lower doses may have a role for your older, frailer patients. The bottom line is that you do need some consolidation. So that's sort of how we think about that.
That was a great recap. And listeners, again, if you want more details on all of that stuff, be sure to check out the last couple of episodes where we went into all this in grave detail. Vivek took us on a lesson, on a journey through, a lot of these pivotal trials and how that shapes our understanding today. And so this is why our patient is getting a lower dose on consecutive days. And I want to point out this difference in relapse-free survival is small, if it even exists, and there's no impact on overall survival. Also, older patients simply have a hard time tolerating higher doses of cytarabine, so it's very appropriate for us to consider the lower dose. So let's say now that we have our patient and she has completed 1 cycle of cytarabine consolidation, and she had another neutropenic fever episode, but overall did well, requiring only a few transfusions. She's not a candidate for allogeneic transplant, as we mentioned. So what is the data behind other maintenance options in this setting for patients who have already undergone intensive chemotherapy for induction?
Now it's time for another history lesson from the fellow on call where everybody falls asleep. So I'm going to reiterate what Dan said. We had the 7+3 chemotherapy backbone that we talked about in a previous episode, really came out of Roswell Park in 1973. And that was our standard backbone for so many years. We changed the dose over time, and then eventually we added some of these targeted inhibitors, but really that stood the test of time, really saying also that, hey, there's a lot more work to be done in AML. But let's talk about this idea that Dan said, the 100% risk of relapse if no consolidation or maintenance is given. And this came from 2 studies, one from the ECOG cooperative group, the other from the German AML group. We're going to link both of these in our show notes. And these were done in the late 70s. So we knew since the late 70s, you cannot have a placebo control arm in a clinical trial for AML patients in the maintenance setting. They must get some consolidation. You got to give them something, or there's a 100% risk of relapse. This is incredibly important as we talk about the pivotal trials that offer potential options for maintenance. And we'll talk about the issues with that. And so the key thing to keep in mind, since 1978, we knew you had to do something. Placebo was not appropriate. We've discussed the idea that allotransplant is a maintenance, quote unquote, maintenance phase of treatment, mainly because we wanted everybody to understand graft versus leukemia effect. But truly what maintenance means is that you give lower doses of chemotherapy to maintain your remission and really to improve cure rates. Really, the hallmark of this is an ALL. So in acute lymphoblastic leukemia, maintenance therapy led to higher cure rates in the pediatric populations, which we have extrapolated now for their AYA and adult populations as well. So that's huge, right? And when we tried the same approaches in AML, there were multiple trials looking at chemotherapy-based approaches. None of them worked. Over several decades, none of them worked. The first couple were the same trials that showed us we needed to do something, because if you did nothing, there's a 100% relapse risk. But even with those other chemotherapy-based maintenance approaches, wasn't great. The only thing that really helped us was the high-dose cytarabine consolidation, which is critical. Then the question was, what other drugs can we try? And there was a push about immunomodulatory drugs. This drug, lenalidomide, seems so good. I mean, it's used in some lymphomas. It's used in myeloma. Maybe this thing will be perfect. Maybe we just need to have an immunomodulatory effect to get rid of some of these residual leukemia cells in a maintenance setting. And this was trialed by the Hovan Cooperative Group in Europe and failed to improve overall survival in the randomized study. Next, checkpoint inhibitors were tried. We always talk about pembrolizumab, nivolumab, these magic drugs that work really well for so many different types of cancers. Didn't work at all in AML. And we'll link all of this to our show notes if you want to check out these trials. And at the same time, investigators knew that hypomethylating agents, including azacitidine and decitabine, were effective in treating AML in older adults and in the refractory setting. So the thought was, what if we use these well-tolerated agents in the maintenance setting?
It's really interesting to see how different AML is from ALL. The approach to ALL is that maintenance is essential to curing these patients with sort of a lower intensity therapy. But in AML, this prolonged low intensity chemotherapy just didn't work. So what's the data behind the use of hypomethylating agents in the maintenance setting for AML? Do we have good trials to support that practice?
Well, before we get to that, I think we should first even just talk about how these drugs work. So remember that gene expression is regulated through methylation of DNA, and that methylation will silence gene expression. And many AML cells have mutations in genes that are responsible for controlling gene expression through methylation. So when these mutations occur, there is increased methylation in downstream genes that are responsible for normal cell differentiation and function. And so this is what we call epigenetic mutations. You may remember this buzzword from college biology, epigenetic mutations, and that's because the DNA for the downstream gene that is being methylated is not affected, but essentially there's too much methylation. And so in effect, there are implications on how gene expression occurs. So hypomethylating agents restore gene function by preventing methylation and silencing. So a good analogy is to imagine that all of your genes are a series of light switches, and methylation will turn the switches off. There are many switches in the off position in AML because of these alterations in the epigenetic pathways, but the downstream genes themselves are not mutated. So these hypomethylating agents go through and they turn all the switches back on, specifically in hopes that the normal gene expression can occur. The problem is that certain genes which should be shut off may therefore be turned on, and vice versa. So the thought in maintenance was that these agents can fix these residual AML cells with epigenetic issues related to overactive gene silencing through methylation. So there were several trials that looked at azacitidine maintenance daily for 5 days, repeated every 4 to 6 weeks for 1 year versus observation. And so the first was the AML-16 trial from the UK NCRI presented at the EHA meeting in 2015, which did not demonstrate improvement in overall survival. There was another phase 3 randomized trial that compared azacitidine observation by the Hovan group that was published in 2019, which showed improved 12-month disease-free survival by 10% absolute percentage points, but no improvement in overall survival. And there was a randomized phase 2 trial using decitabine maintenance called E2906 from the ECOG cooperative group. And this was designed as a pilot study from a parent trial looking at intermediate dose cytarabine, which they defined as 1.5 grams per meter squared, versus a drug called clofarabine in consolidation, which showed that intermediate dose cytarabine was superior. There were 120 patients from the parent study who were randomized to decitabine versus observation for maintenance, and there was no statistically significant difference in disease-free survival or overall survival, but there was a trend towards improved disease-free survival. The bottom line is that there was some evidence that disease-free survival may be improved with HMA maintenance, but overall there was no difference in overall survival.
Let's take a moment to learn more about the sponsor for today's episode. Imagine there was a way you could use your expertise as a healthcare professional to contribute to medicine, to improve the patient experience, and help impact the development of new drugs and devices, all while making some extra money.
We have the solution. Market research surveys through our partners, M3 Global Research, All Global Circle, and M Panels. Through their easily accessible and secure platforms, you can complete market surveys on your own time. It's the perfect way to make some extra money while making a difference. It's so easy, and we couldn't recommend it more.
To learn more and to sign up, use the special TFOC link on our website, thefellowoncall.com, and in the description box below.
And I think these studies are really important to highlight, right? So when you have an improved disease-free survival in the maintenance setting, that's kind of obvious, right? Something is better than nothing. We've kind of talked about this in other series before, right? If you're giving something, of course that's better than nothing. But the key thing that you want is that giving this something now, which you know has more toxicity, is going to improve the trajectory of the disease and improve overall survival. But what's happening in these patients is, sure, you might delay the time to disease relapse with these agents, but overall, once that relapse occurs, that's really bad leukemia, and you've kind of ran out of bag of tricks, right? This leukemia is more resistant, it tends to be worse, and that's why we're not seeing these improvements in overall survival, because that's really what we want, right? It's not just delaying disease progression by giving something, because it's more obvious, right? We want to fundamentally, the fundamental goal of maintenance therapy is to improve overall survival. So again, it's logical to use this HMA therapy in this maintenance setting because lower side effects. And now we have these hints that there might be efficacy. Some of the concern was, well, this is an IV medication. You're getting this for 5 days. Maybe patients aren't as compliant. What if we had a pill for this? What if we tried an oral medication? And this leads us back to our patient who's asking about oral azacitidine maintenance. So there's an oral version that was created. So can we go over the Quasar trial that led to the approval of this drug? And also, let's discuss why we rarely ever see it used in practice.
Sure. This study was published in New England Journal, and it's a credit to the New England Journal. It's rare for an NEJM paper to not actually influence our standard of care. But this is a perfect example of a trial that had significant design flaws. It ultimately led to a drug approval, but at best had marginal benefits. The study included adult patients who underwent intensive chemotherapy and achieved a complete remission, but were not fit for allogeneic stem cell transplant. Patients were randomized within 4 months of achieving a CR after their initial induction therapy, either to oral azacitidine or to a placebo agent. Red flag, right? This was a double-blind study, so both the investigator and patient did not know whether they were on placebo or trial drug, gold standard for prospective evidence. And the patients got their maintenance therapy on days 1 through 14 for 28-day cycles. All patients got a bone marrow biopsy every 3 months for 2 years. And if there was relapse in the bone marrow and it had 5 to 15% blasts, then the investigator could choose to increase the drug to days 1 through 21, so adding an extra week of therapy each cycle, with the hope of maybe deepening that response, getting them back into a remission. So you did hear that correctly. This is a double-blind trial where a patient with AML relapse could simply have their placebo increased in intensity. I'm going to be measured in my criticism of that, but I do not think that is a good idea. Patients were not required to have 1 or more cycles of HiDAC or IDAC consolidation, which is also a giant limitation in the study because we know from those old trials that no consolidation therapy, kind of jumping straight to a quote maintenance or potentially placebo, leads to a disease relapse of 100%. Like 100% of those patients are going to relapse. So it's an interesting comparison arm. There were 472 patients randomized to both arms, and imagine that there was a statistically significant improvement in both relapse-free survival and overall survival when you do something instead of nothing. Not really groundbreaking, but that's where we are, and that's how we ended up getting the approval on this drug.
So we finally got a trial that improved overall survival in the maintenance setting. But as you pointed out, there are some glaring issues with the design. And I'm sure this is on everybody's mind, but how many patients got no consolidation and how many patients just got placebo when they had overt relapse of AML in their marrow? Also, was this drug even well tolerated?
So this is absolutely crazy, but 20% of the patients in the study had no consolidation therapy. And we knew every single one of those patients are going to relapse if they get placebo. So you're literally putting your thumb on the scale in favor of something is better than nothing. And that is not standard of care at all. There were also 20% of patients, a fifth of patients, 1 in 5 patients enrolled in the study, who just got the increased dose of the placebo instead of using salvage therapy when they had relapse on these every 3 months marrows, which is crazy, right? If you have a patient who has AML relapse, you're going straight to the next therapy. These diseases can ramp up and get out of control very, very quickly. The other major issue is that most of these patients were actually quite fit. And this delayed time to salvage therapies probably led to worse overall survival in that placebo arm because they're not getting any active drug. 65% of all these patients got a subsequent therapy, and over a third of the patients got a subsequent intensive chemotherapy at relapse. So it's not like they were so frail they couldn't get HiDAC consolidation, right? Even though 20% of the patients got nothing. Interestingly, in this quote-unquote not fit for transplant trial, about 15% of patients ended up getting an allogeneic stem cell transplant. So these patients are generally fit. It's very unclear who they were choosing to enroll in this trial. There's huge issues because you have to have some consolidation. We've known that, and that wasn't standard on this trial. In terms of how well it's tolerated, the side effect profile of oral azacitidine is not great. Over 60% of patients had GI toxicity with some combination of nausea, vomiting, or diarrhea. There was double the rate of severe neutropenia compared to placebo, and nearly half these patients required dose interruptions due to toxicity. These really trial-suited patients. So imagine generalizing that to our regular population. And the last big thing I want to highlight is the impact of consolidation therapy. At the ASH oral presentation, they really showed that the benefit of maintenance was less impressive in those who got more cycles of consolidation cytarabine. So meaning, if you got what you're supposed to get, it really didn't do that much, as we've seen in all of the other studies in terms of overall survival. We love looking at the supplementary appendix here at the Fellow on Call, so check out figure S2, and you'll see that those who received 3 cycles of consolidation therapy had no benefit from oral azacitidine maintenance. And at the ASH presentation, this held true for 2 cycles as well. They nested the groups as 1 and 2 in this study just to make it seem like it was helping those who got consolidation therapy, but really wasn't the case. So at the end of the day, this really is not one of the things that is standard of care for our patients.
So it seems pretty clear that we should not be giving oral azacitidine maintenance to our patients who got intensive chemotherapy induction because of very limited generalizability of that study in the real world. It also highlights the importance of looking at patient inclusion and post-protocol therapy for trials, even if there's a statistically significant finding, because it's published in a high-impact journal, because that sort of analysis and that critical thinking and that critical appraisal really tells you whether or not that finding is clinically relevant, which is so essential. We discussed those results and those caveats with our patient, and she opted to just complete 3 cycles of cytarabine consolidation at 1.5 grams per meter squared. And 1 year later, she's still in remission. Let's change the case up a little bit now. We now have so many targeted therapies for our patients with AML and specific mutations. So let's go ahead and say we have a 60-year-old male with AML, and it's FLT3, FLT3 ITD mutated. He underwent 7 and 3 plus midostaurin based on the RATIFY trial and achieved a complete remission. He then proceeded to HiDAC consolidation and ultimately underwent matched unrelated donor allogeneic transplant. He's doing well at day 100, got a little bit of mild GVHD of the skin, but otherwise is doing great, and asks whether he should go back on his targeted pill maintenance or not. So let's talk about some of these FLT3, FLT3 inhibitors in the maintenance setting. What FLT3 inhibitors are available, just overall?
So it's important to know that historically the TKI sorafenib was used to treat FLT3 mutated AML. And honestly, in all of my time in fellowship and now, I don't think I've ever seen a patient on sorafenib, but it's important to be aware of because number one, you may see it in your question banks when you're studying for your exams, and 2, it is still the historical standard. So sorafenib is far less targeted than the drugs that we see nowadays, like midostaurin and gilteritinib and quizartinib. So sorafenib was the first kid on the block and has data for utility in the post-transplant maintenance setting, which we will discuss. In our induction episodes, we went over the RATIFY trial and the Quantum First trial, which led to the approval of 7 plus 3 plus midostaurin and 7 plus 3 plus quizartinib, respectively. Remember that quizartinib is only used for FLT3 ITD, but midostaurin can be used for the TKD or ITD mutation of FLT3. Gilteritinib was approved in the relapse refractory setting based on the Admiral trial, which we will discuss in a future episode, but important to know that this is the drug of choice in this setting as we talk about the maintenance data. So again, go back and listen to this. This is not only clinically relevant, but just from recent experience, this may be something testable for your boards.
Okay, perfect. So we have a patient who is FLT3 ITD mutated and doing well post-allo. We know that many of these patients will still relapse, FLT3-ITD being a fairly aggressive disease biology. And so this is where that concept of maintenance could be beneficial, particularly with these targeted agents that could potentially kind of snipe out that residual disease. What's the data behind targeted therapy in this setting, in a specific maintenance setting?
I'll say that targeted therapy for IDH1 inhibitors, IDH2 inhibitors are still evolving, but we have more data in the FLT3 positive setting. So as Ronak mentioned, there was early data showing the efficacy of sorafenib in the patients who received an allogeneic transplant and had FLT3 positive disease and were on sorafenib in the post-transplant maintenance setting. And one of the best studies for this was the randomized phase 2 SORMAIN trial, which was published in JCO 2020. Check out our show notes for a lot of the details, but in short, patients who were randomized to either sorafenib maintenance or placebo after an allo transplant, and there was a statistically significant improvement in relapse-free survival and a trend towards overall survival. The 24-month relapse-free survival was 85% compared to 53%, so it seemed like a pretty big gain. And interestingly, in subgroup analysis, there was a benefit in MRD positive patients, but not MRD negative patients. There are many limitations of this trial because one of the biggest ones is that patients in induction before transplant didn't receive FLT3 inhibitor. So it's not reflecting the patient population we see today. Every patient today is either getting midostaurin or quizartinib in the induction setting. And this trial, not because they wanted to design it in a bad way, just the drugs weren't approved yet. So we don't have the answer to our question today. If they got FLT3 inhibitor in the induction setting, does it help in maintenance? We know if they didn't get it induction, then it does seem to help in maintenance based on this phase 2 SORMAIN trial. And likely the results were exaggerated because it was a small phase 2 study. And we know when you have underpowered studies, if you find a significant result, it's exaggerated. The difference is a lot more than what it actually likely is in real life, in the real world. There was another trial looking at midostaurin in the post-transplant maintenance setting called the RADIUS trial with no improvement in relapse-free survival or overall survival. So this should make your head kind of spin a little bit, right? Why is there no improvement there? Why was there no improvement in overall survival in the SORMAIN study with this old drug sorafenib, which really was being used? And that leads us to the trial called the MORPHO trial, which was published in the JCO in 2024. And this really evaluated the drug gilteritinib in the post-transplant maintenance setting. So can one of you go over that data in the MORPHO trial?
Sure. Remember that gilteritinib was approved in the relapse refractory setting, and frontline midostaurin was improved in the induction setting. We would expect that in this study, patients should have received 7+3 plus midostaurin as induction, followed by transplant. And if they relapsed, they should get gilteritinib as their salvage therapy. But as you will see, this is not the case. And so we're still really not left with a great answer. In this study, patients were randomized to gilteritinib versus placebo for 2 years after transplant, just upfront. There were 356 patients included, and only 60 of these patients got a FLT3 inhibitor prior to their transplant. Of note, this was driven by patients being enrolled outside of the US and possible lack of approval for those targeted agents in those other countries, but kind of unclear what the reason was for that low percentage. There was no statistically significant difference in relapse-free survival or overall survival in the entire population. Notably, the 2-year relapse-free survival was 77% in the gilteritinib arm and 70% in the placebo arm. A 7% overall difference, but the p-value was not significant, 0.052, so didn't quite make it. There was no difference in overall survival with a p-value of 0.44, and there was a higher non-relapse mortality in the gilteritinib arm. We also don't know how many patients in the placebo arm got gilteritinib at relapse, which is really the important question. Should we give it up front or should we wait until relapse to give it? That would have been a great thing to answer. Unfortunately, we just don't have that. A post-hoc analysis did show that patients who were MRD positive before or after their transplant, so pre or post-transplant, had a significant relapse-free survival benefit with this strategy of including gilteritinib as a maintenance therapy up front. We'll have the link to these studies in our show notes, but a little unsatisfying overall for a very important question in post-transplant therapy.
And one thing I want to point out is that this relapse-free survival was not statistically different because of a p-value of 0.052. That barely does not meet statistical significance. And that's more of sort of just a nuanced point, right? That, well, it's technically not less than 0.05, but barely, right? And so a purist would say, well, it doesn't meet statistical significance. But realistically, there's probably some difference there. The key thing to know is the way this study was designed and powered, it's not that big. It's probably a lot smaller. And that's why it wasn't significant for the margins that we chose. If we had chosen a smaller margin with a lot more patients, maybe we would have found that difference. Breast cancer trials are blessed to have so many patients enrolled in that trials, right? It's just one of those things that they're able to get better data, right? There's a chance that that would have been the case here. The other thing that's quite difficult is how do we interpret this MRD signal? It was really done to understand the prognostic significance. And what we want to really highlight here, and I think this is an important thing to know, MRD positivity prior to transplant is a poor prognostic factor. It does not mean that you shouldn't transplant those patients. That's not what this study is telling you. It is saying that, okay, well, in this study and in the SORMAIN study, both two studies, SORMAIN and this one, for patients who are MRD positive, they benefited from a maintenance therapy with a FLT3 inhibitor. And that's the way you could interpret it. Whether that's right or wrong, that's up for debate, because at the end of the day, we don't have our full answer, right? Does giving gilteritinib in maintenance now what we need to do, or should we just wait if the patient relapsed and give it then? Is it really going to change the trajectory of the disease for patients with bad disease who relapse after transplant? Did it change that patient group? Or are we just over-treating a bunch of patients who were never going to relapse anyway, right? That is the big question when it comes to these patients, and we still, unfortunately, don't have that answer.
Gosh, that was just a lot of really, really important information. And honestly, I didn't know about all these different trials with regards to especially things like gilteritinib and the things that led to its approval and these small differences. But Vivek, as you're alluding to, I mean, relatively speaking, I know you brought up the example of breast cancer. AML is a relatively rare disease. And so even for us to be able to have drugs like this that are still making significant improvements in patients' lives based on the trial data that we have, it's sort of the best we got. And I'm glad that we still have options to give our patients. Guys, what final thoughts do you have, if any?
I mean, as always, I feel like we need better drugs. We need more drugs in this setting. It's clear that I think there's room for improvement on our maintenance therapies. I just wish we had an answer to some of these questions.
One thing I'll say is just because it was published in New England Journal of Medicine doesn't mean that there's not issues. And you must look at what were the inclusion criteria. What did the patients get after they relapsed if we're looking at overall survival in cancer studies?
The contrast to these couple of studies, I think, draws out a really important point about our reliance on p-values. A lot of statisticians chafe at our insistence on a tyrannical p-value, where this is the be-all and end-all. Take everything into context, understand how the study was performed, what the limitations are on that interpretation. The statistical significance is still a very important benchmark that we all have agreed upon, as this is the level of a difference that we consider to not be just a random variation. But again, a lot goes into that calculation, and we really need to be thoughtful about these studies.
Such an important reminder, guys. And thanks for reminding our listeners about that too. All right. Well, I think that wraps up another fantastic episode of The Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.